Welcome to podcast 10.
I'm Fran.
And I'm Minnie.
And as always, we really appreciate your feedback. And in fact, this week's topic is coming to you courtesy of Joan, who requested it. So what's our topic, Minnie?
So this podcast topic is heart failure. And our tip is to check the ankles for swelling in patients that present to you with shortness of breath.
Brilliant, thank you.
So we're going to present a case and talk you through heart failure using the case as an example. We hope you find this useful. So today, a 54-year-old man has presented with a 3-month history of worsening exertional dyspnea. So that's shortness of breath on exercise. He's currently smoking 40 cigarettes a day and also has a positive family history for ischemic heart disease. Looking at other risk factors, he has no history of hypertension or of diabetes. Now, when he started getting shortness of breath, he noticed it when he was walking up slopes, and this started about 3 months ago. And since then, it's progressed to him getting breathless, walking a mile on flat ground. Now, you can class the shortness of breath and the symptoms using the New York Heart Association classification. This would be class 2. Fran, do you think you could tell us a bit more about that?
Yes, and in fact what I'll do is I'll post this up on the forum. So this is just a way of gauging the severity of somebody's heart failure, and you can then use it to assess the patient each time you see them to see whether the medication is helping them improve so that they've come down the classification, or whether in fact their heart failure is worsening and they are coming towards the end stage of life. So it's classed. So class 1 is with no limitation of physical activity. Class 2 is a slight limitation. So for example, with this patient, so they're comfortable at rest, but ordinary physical activity results in some fatigue or palpitations, breathlessness, or some angina. Okay. 3 is more marked limitation in physical activity, and then 4 is the inability to carry out any physical activity without discomfort.
Okay, so that will definitely help you in terms of treatments, especially with the later ones, I would imagine, as to when to change to a more sort of palliative treatment.
Yeah, and I think, to be honest, that's probably what I use it for in practice most. I don't think to myself each time I see a patient, which classification are they? We're all pressed for time, and I certainly don't have time to sit down and run through this with each patient. But it would be something that I would be doing each year for my patients with heart failure, just to see where they are. And I think, again, heart failure is very difficult in the end stages to know when you should start using palliative care rather than a sort of active treatment. And like you say, this could be used as a guide. So anyway, I'll post it up on the forum, and you guys can have a look, because it's good to know what other people are using.
Great. So if we get back to our patient, he has no, we're asking him about further symptoms. So he says he has no chest pain, he doesn't have a cough, and he can lie flat in bed, so he has no orthopnea. But he has had 5 episodes of waking in the night, gasping for breath, which has made him jump up and run to the get to the window. And this is a paroxysmal nocturnal dyspnea. Okay, so move on to his examination. He has a blood pressure of 124/60 with a regular pulse of 96 beats per minute. His heart sounds are normal, but you notice some bibasal crepitations and some mild ankle swelling. So with the history and this examination, you make a clinical diagnosis of heart failure. So what is heart failure, Fran?
So heart failure occurs when the heart is failing to pump enough blood around the body. And the symptoms, as our patient have described, are classically shortness of breath, orthopnea, which is when your patient's needing to prop themselves up in bed, and typically we always ask the number of pillows somebody needs to sleep with. This paroxysmal nocturnal dyspnea, which is often shortened to PND, reduced exercise tolerance, fatigue, and swelling of ankles. And then, of course, you can get sort of more vague symptoms, more systemic symptoms, things like nocturnal cough. You can get a cardiac wheeze from the fluid on the lungs, loss of appetite, weight loss, maybe confusion in the elderly as well. Okay. And it is relatively common. The prevalence in the UK is 8.3 per 1,000 population. But what we are finding is it's rising because in the UK we have an increasing elderly population, and mostly this is because people are surviving what we call ischemic events. So in the past a heart attack would maybe have killed someone, but in the UK with better medicine, people are now surviving heart attacks, they're surviving strokes, they're living longer with their hypertension. And okay. in fact, reflecting on that, hypertension and ischemic heart disease are the two main causes of heart failure. So that's really what we're looking at, causing the majority of the problems that preventing the heart to pump so well.
So with our previous podcast on hypertension, that just sort of highlights the importance of checking blood pressures and treating where necessary.
Absolutely. And treating how we would term in medicine, treating it aggressively. There's no point sort of half treating blood pressure. If you're going to treat it, get it down, because it does prevent these problems. There are, of course, other cardiac causes such as atrial fibrillation, valve disease, and the more rare cardiomyopathies. And again, other things as well. So endocrine problems such as thyroid disorders, diabetes, toxins such as alcohol and recreational drugs, nutritional. So pellagra, which is something certainly we have noticed coming from Zambia. So being careful of people, that actually not getting the right vitamins can be incredibly detrimental to your body. Anemia and end-stage kidney failure.
Sorry, just going back to the nutritional state, Fran. So any sort of malnutrition can end up tipping you into heart failure, I think, can't it? So is that because it causes a high output sort of failure generally? I think it put in the way that it does in anemia. Yes, I think
you're right, Minnie. Yes, I think you're absolutely right. Yeah. And it just goes to show, doesn't it, how how nutrition and alcohol and all these things are so important for keeping people well. It's extraordinary, the importance of avoiding excess alcohol and eating well if you can, and obviously we're very lucky in the UK that we have the ability in general to eat a good diet.
I think one other cause which may be particularly relevant for you in Zambia is infection and immune mediated problems. So HIV is another cause that can cause heart failure, and parasitic infections, and things like rheumatoid arthritis or other autoimmune diseases. I suppose that overlaps with the thyroid as well, doesn't it?
Yes. Okay. Yes. Yes. No, I hadn't thought about that. Yeah. And you have to be very suspicious. So interestingly, I'm going to say a young patient because he was younger than me, and normally fit and well, and he presented with just a cough that wasn't quite right, and his chest x-ray was fine. And in fact, I wasn't really sure, and I ended up sending him up to hospital on a slight hunch, and it transpired that he had an undiagnosed cardiomyopathy and was in heart failure.
Wow.
Yeah. So you do have to be suspicious about these things because sometimes it's not when you expect it. So moving on to the investigations, reflecting that. So with the investigations, effectively, you're looking to see if it's any of these other problems that have caused it. So ideally, you would be doing, their full blood count to see if they're anemic, their kidney function to see if they're in kidney failure, checking their thyroid, checking their liver, sugars for diabetes, and then their fasting lipids. Because with heart failure, you're looking at it being a cardiovascular problem. So if their cholesterol is high, then you'd want to be tackling that as well. Ideally, you'd be looking to do an ECG as well, and that would give you evidence of perhaps some previous heart attack or myocardial infarction, or whether they have an arrhythmia such as atrial fibrillation, a chest x-ray. So my understanding is that chest x-rays are not good for diagnosing heart failure. but they are very good to exclude other causes of shortness of breath. So it's not so much saying, let's do a chest x-ray to make sure we have the right diagnosis. It's a question of saying, let's do a chest x-ray to make sure they don't have lung cancer, which is causing it. They don't have a pneumonia, which could be causing it. But actually, the gold standard in the UK is a blood test called BNP, which we use. And if that is raised, that is a strong marker for heart failure. And we do an echocardiography, which is an ultrasound of the heart. And that can then look at how well the heart is functioning, and it can look at the valves to see if there's any problems there.
Okay, so that's your gold standard. Obviously, if those aren't available to you, you need to make a clinical diagnosis more, don't you?
Yeah, and I think, to be honest, so for me, if someone presented like this patient, I would be treating them clinically as heart failure, and I would perhaps be doing the tests alongside, but I certainly wouldn't be waiting for them to make my diagnosis. Mm-hmm. You know, we're clinicians. We should be diagnosing this clinically, and the tests are there just to back up or refute our diagnosis. So, you know, if you don't have any of these tests, get on and treat that patient. You know, treat them. If it works, you've got the right diagnosis. If it doesn't work, re-examine, think again. Exactly. Yeah.
Okay.
So what echoes have enabled us to do is to diagnose between two different types of heart failure. And the difference is made depending on what's called the ejection fraction. And that's the amount of blood that's pumped out from the ventricles with each contraction. And if your ejection fraction is 50% or above, that's deemed to be normal.
Right.
And if it is below that, then you have heart failure. So the simplest, so type 1 diagnosis is what we call left ventricular systolic dysfunction. So that's when your left ventricle, which pumps the blood around your body, out to your limbs and to your head, that's when it is not pumping so well. This is a really classic type of heart failure, and it is mostly caused by myocardial infarctions. Okay, and so the abbreviation for that is LVSD. Sorry, guys, there's lots of abbreviations. And then the other type of heart failure is heart failure with preserved or normal ejection fraction. So that does not trip off the tongue. And that is shortened to HFpEF. Don't ask.
Okay.
But the old-fashioned term for this is diastolic failure. So this is when it isn't pumping so well when the heart is relaxed in diastole. So it's got a normal left ventricular ejection fraction, but it's not pumping so well in diastole. And this is mainly caused by high blood pressure. And you may say, well, you know, really, what does it matter? Because they're both causing the same symptoms. Well, all the research has been done on the LVSD. So we know that there are some medicines that improve outcomes for that. But what we don't know is what medicines make a difference with the HFpEF. Okay. So that's why we distinguish in the UK. Now, obviously, I do know that some people have been able to get echoes in Zambia because I have had some reports of those. But for lots of you guys, you can't get an echo. So it is just about treating the heart failure as best we can. Okay.
And as time goes by, hopefully echoes will become more available for you as well, and you'll be able to...
Yeah. And I think as more people have heart failure, then they'll do more research into treatments for diastolic failure, and then again, you know, we'll be able to treat that better as well. Yeah. So what are we going to do with this patient?
So with our patient, we're going to start him on a diuretic. So we're starting on furosemide, 40 milligrams twice a day, morning and lunchtime, so that he doesn't get a disturbing nocturnal diuresis, and then see him again in 2 weeks' time.
Okay, so we're treating him symptomatically, aren't we? We're treating the fluid on his lungs and in his ankles. Brilliant.
And whilst giving him some medication, we also need to give him some advice about his lifestyle to reduce those other risk factors. So reducing salt in his diet and reducing alcohol intake, and also to encourage him to stop smoking, which is important, obviously, for all cardiovascular morbidity, really, and increases exercise at a low intensity.
There are very few things that increasing your exercise don't improve, aren't there? I mean, I think, with pretty much everyone, I think, even if it is just a walk, it is better than nothing.
Yeah.
And that, improves, it's good for the heart, it's good for his lungs.
And good for your mental well-being as well.
Absolutely. Fantastic.
The other thing that if it's available to your patient, you can suggest that they weigh themselves daily. First thing, same time every day after they've been to the loo. And if they are losing weight, so if they've lost 1.5 to 2 kilograms over 2 days, then they need to increase their diuretics. Is that
No,
right?
if they've gained weight.
The wrong way round.
The wrong way around. So if they are
Sorry.
gaining weight, it means they're taking on more fluid, and therefore they need to increase their diuretics.
Sorry, that.
And but it's just a very easy way for patients to keep an eye on their symptoms themselves, and not all patients will really understand it.
Clearly, I didn't either.
Yeah. But it's for people perhaps who maybe present regularly with their heart failure worsening, it's just a quick way for them to up their diuretics to stop it becoming very severe and needing hospitalisation. Yeah.
Okay. And the other thing we do for our patient is the investigations that you've already mentioned.
Yeah, fantastic. So I think going back to the two types of heart failure. So obviously in our patient we aren't going to do an echo, but if we discovered he had the HEPF, the most important thing is that we treat any underlying causes that might be exacerbating that. So that would be high blood pressure, for example. So we would be treating his blood pressure. If he was in atrial fibrillation, we'd be reducing his heart rate. If he was anemic, we would either be giving him iron or transfusing him. But mostly it's about using diuretics such as furosemide to control his symptoms.
Okay.
So that would be exactly what we do.
It's a bit different for the LVSD type, isn't it?
Yes. So for that, the evidence is to use ACE inhibitors or ARBs. There's poor evidence for this in Afro-Caribbean patients, and obviously in the UK you would be checking their renal function regularly, and beta blockers. So those are the two mainstays of drugs, and the idea is that you get them to the maximum dose that their blood pressure and their pulse will tolerate. Yeah. So interestingly, I was on a course recently, and they were saying that actually, because in Afro-Caribbeans there's much more high blood pressure than in other populations, that heart failure is much more likely to be high blood pressure related. So instead of using an ACE, which we know doesn't work terribly well in these populations, you're much better using something like hydralazine or isosorbide mononitrate. Plus the beta blocker. Yeah.
That's important.
So then again, So I wouldn't be going to an ACE as my first line, particularly in a place where I couldn't be checking their kidney function regularly. It's much less safe. Again, you would use the diuretic, but just for symptoms. So that would be initially furosemide, and in very late stages in the UK, we sometimes add in spironolactone, but there is quite a risk of them getting a high potassium with this. And again, you would need to monitor their kidney function. So if you didn't have that possibility, I would be very, very cautious about adding that in. Yeah.
Okay. So hopefully you'll be able to get an ECG on your patient if possible. And our patient has evidence of an old myocardial infarction. So we've selected to start him on a beta blocker. And it needs to be a cardioselective one if you have it available. So something like carvedilol, which is actually given twice a day, and we'll put the doses on the forum for you, providing there's no contraindication for them to be on a beta blocker. Then we need to review and increase the dose as it's tolerated and according to his blood pressure and pulse.
Yeah. So very often, my experience mainly with these patients is that in the UK is that their blood pressure can be quite low, and so it's always this balancing act, because we know that the furosemide will lower their blood pressure, then you're putting them on a beta blocker which will lower their blood pressure, and so you have to titrate very, very carefully, particularly in old people, because you don't want them falling over and then breaking hips, which is obviously another risk factor. And one of the ways, sorry guys if you know this, but to know if they are getting enough beta blocker is to check their pulse. So if their pulse is down, say at about 60 resting, that means that the beta blocker is working, because beta blockers work by reducing the pulse. But if their pulse is still sort of 80, 90, something like that, then their dose of beta blocker isn't enough.
Okay.
Yeah.
Great.
So what's the prognosis for this patient of ours, Minnie?
Well, a diagnosis of heart failure often doesn't give you a great prognosis. And although there have been lots of advances in management, more than half of your patients, certainly with severe heart failure, tend to die within a year. So the most important thing with treatment really is symptom control.
Yeah, I think that's really important. And actually, having said that, I find that they're dying less, which is on a really, on a slightly positive note. That actually, I think, I think medicine has got better, and probably we're catching them earlier. So it's not that, obviously when they're severe, then obviously their prognosis is poor. But actually, if they have much milder heart failure, then we are better at treating them. But what I do with you talking about end of life care, I think it's really important for us to realise when they're in that. So using that New York Heart Association classification. So when they're at stage 4 and things are very bad. So interestingly, you can use oral morphine, and it works very well for the symptom of shortness of breath. Yeah. And it just calms the breathing down, because being short of breath is a very scary experience for patients. And just a very low dose of that can help with the shortness of breath. And also, it's very fashionable at the moment. The term is deprescribing. So, for example, with this patient, say his cholesterol had been high and you'd started a statin, or, we had him on a beta blocker. Do you actually need those? If the patient is dying, do you need those? Probably not. You would just keep on his diuretic, which you're using for his symptom control, but medicines which you might have been using to help prolong his outcome, just stop them. And this is something that I'm starting to get much better at, and it's very hard because it kind of goes against our nature as doctors. But I have a lot of elderly patients in nursing homes, and very often the first thing I do is I go through their medicines and I think, actually, which of these do they really need this? If they're, they're 96 and they're demented, do they need a statin? They've got heart failure. Do they still need, X, Y? Let's take them off. Let's make the burden of medicines a little bit more tolerable. Yeah.
Great. Well, thank you for that, Fran. Very interesting discussion there on heart failure.
Yeah, and I think probably, like we say, things are changing, and then if we're still doing this in a year or two, probably we'll need to do it again because there'll be new evidence out there.
Yeah, absolutely.
Yeah, always learning,
aren't we just?
Yeah.
Okay, well, thanks for listening, and
you.
Give us any feedback as you feel fit.
Brilliant. Goodbye from me.
And bye from me.